Good afternoon, ladies and gentlemen, and welcome to May's meeting of the local COVID Outbreak Engagement Board. Item 2 on today's agenda is the notice of recording. So to inform everybody in the meeting that this meeting will be webcast for live or subsequent broadcast via the Council's internet site. Members of the press and public may record and take photographs if they wish to do so. The whole of this meeting will be filmed, except where there are confidential or exempt items. I don't think we have any on today's agenda. A little bit of housekeeping. Could I just ask those who wish to speak and make a contribution to the meeting, please to raise your electronic hand to indicate you want to speak, and I will call you in. Except where you are speaking, could I ask everyone please to mute their microphones and turn their video feed off, as that will help with bandwidth, particularly for those whose internet connection is not particularly good. Thank you. Item 3 is apologies, and given we've recently had local elections, you'd perhaps not be surprised to hear that we have apologies from 3 elected members who are recovering from those elections. Those are Councillor Bridget Jones, Councillor Paul Hamilton and Councillor Matt Bennett. I also have an apology from Paul Jennings with Paul Sherritt substituting, Dr. Justine Varney with Dara Fahy substituting, and from Pip Mayo and Elizabeth Griffiths. Are there any other apologies anybody wishes to give? No, in which case we will note all of those apologies. Item 4 is declarations of interest. Does anybody wish to declare an interest in respect of an agenda item on today's agenda?
Leader.
Dara, were you wanting to speak?
No, I just said none from me, Leader.
Okay, thank you. In which case we don't have any declaration of interest then. Item 5 is the minutes. Are we all content that they are accurate from our meeting held on 28th of April? Thank you. Which takes us on to item 6, which is the COVID-19 situation update. Dara is going to present the slides on this. Dara, there's a multitude of slides here that have been circulated. I think if we can assume everybody's had the opportunity to look at them, and if you just want to give us a summary rather than talk us through each and every slide. Thank you.
Okay, no problem. So hopefully you can see those slides.
Yes, we can.
Okay, great. I just want to check one thing here. Okay, it's not quite giving me that. Okay, well, I suppose just going on to the third slide there, the fourth slide, which really looks at the overall rates up until the 23rd of May. I think the kind of most salient point is really that our rates have increased compared to the last week. Our rates now are 23 per 100,000, whereas previously they were down at 16 per 100,000. And this does represent a slight upturn of roughly 45% compared to the previous week. And if we look at the previous 2-3 weeks, Birmingham was continuing to trend downwards in terms of its rates and went from a position where its rates were consistently higher than those of the English average rates to one where it was lower than the English rates. Currently, we're at the same rate as the English rate, so we need to be very careful in terms of monitoring that, and we'll come back to possible reasons for that when we talk about the Indian variant. And currently, it's ranked first in the West Midlands region. Just the only thing to say about the testing rates, which is quite significant, is that we've seen an increase in positivity, a significant increase in positivity with the PCR testing, which has increased from 1.3%, whereas previously it was at 0.9%, although it has increased nationally as well to 1.2%. And actually, just kind of even if we go back a slide, just to slide 3 there, if you look at the second graph, you'll see how, as we kind of had seen trended from maybe January or previously, prior to that, we'd seen the rates continue to go down and down and down, and then the slight uptake just recently in the past week or two. So just to monitor that carefully. When we look at the map, we can see that most of the cases are kind of focused around the central part of the country, or sorry, of the county, and this just reflects the top 10 case rates by ward. So the highest rates in the past week around Lozells, Bordsey and Highgate, Pipe Hayes and Holgreen South. I won't go into the wastewater report, but that just again shows that there is considerable evidence of variants of concern in our wastewater, which is often very helpful epidemiological data. The part that I probably want to focus on the most is the variants of concern, which we know often are more infectious, have higher rates of hospitalization or mortality, or can be more vaccine resistant to the other variants. So the key variants of concern that we tend to focus on nationally, and particularly in Birmingham, is the UK Kent variant, which at the moment represents the majority of new cases in Birmingham. But actually, if you look at the figures nationally, the Indian variant has overtaken the UK Kent variant as the more predominant strain. And if you look at data for both the West Midlands and Birmingham, you'll see that our rates of the Indian variant are starting to increase, whereas our rates of the Kent variant are starting to decrease. So there's a very real possibility that we'll get to a situation where the Indian variant takes over from the Kent variant in Birmingham. And the reason why that's significant is that, the main reason is it's thought to be 1.6 times more transmissible. So it should have more of an impact in terms of mortality and morbidity. Of course, a lot of this is contingent on the level of vaccination. And we do know that those who are vaccinated do receive a good level of protection against this variant. It's probably not quite as strong as the protection you get against the Kent variant, but I think it's still quite significant. So if we look at the actual number of cases in Birmingham, there's been 26 cases of the South African variant and 43 cases of the Indian variant. The other variant of concern is the Brazilian one, although we've only seen one case so far in Birmingham. Now, one of the things that you might start coming across is what's called the S gene positivity. And so normally what happens if you do a PCR test, it goes off to a lab for genomic sequencing, and that'll tell us which variant of concern it is. However, by actually looking at whether the virus is S gene positive, we have a mechanism which is much quicker and easier and cheaper than the genomic sequencing to give us a very strong indication of what kind of variant of concern we might have in Birmingham. Because effectively, if you have the UK or Kent variant, you'll be S gene negative. Whereas if it's the South African or Indian variant, it'll be S gene positive. And a study was done, or an epidemiological review was done between the 6th of May and the 19th of May in Birmingham, and we found 133 S gene positive cases. So there's quite a lot of variants of concern circulating at the moment in Birmingham, and we feel those rates are continuing to increase. There was also a sample of 46% of samples were tested for the S gene in Birmingham, and 63% were S gene positive. So what we're seeing across Birmingham, and it's reflected across West Midlands, is rather than seeing one or two core epicenters that are generating the high numbers, we're actually seeing quite a large sprinkling of cases across Birmingham and across the West Midlands. And a lot of these are linked through travel or through community contact, but no real core epicenters. And we're particularly seeing the cluster cases in certain schools like Hall Green North, and higher rates in places like Hodge Hill and Lozells. And this graph here, particularly the graph on the right, just shows that the actual rate of change in terms of the increased numbers of the variants of concern, the Indian variant of concern, is increasing quite significantly in Birmingham. And the particular reason why that's of concern is that, from talking to people who were in the northwest, where they have very high numbers of the Indian variant, what they found was it was a gradual increase initially, and then it rose exponentially. So clearly that's something we want to avoid in Birmingham. And effectively our response is a combination of adhering to the national directives as well as our own local response. So, for example, we're expediting the second dose so that everybody gets their vaccination within 8 weeks as opposed to 12 weeks. We have pop-up vaccination clinics that we have in place in areas where we think there are high rates. We have focused surge testing in response to linked clusters. So this isn't quite the Operation Eagle type response, but it really is trying to identify clusters that are epidemiologically linked and ensuring that all the cases and contacts are have PCR testing, have enhanced contact testing, and we also leverage the environmental health officers to ensure enforcement of isolation and compliance is in place. And that's all combined with very focused communication and engagement so people understand the relevance of the Indian variant. You will have heard that in certain parts of the UK, such as Bolton, the government has basically introduced tier 2 restrictions for those cities and boroughs, whereas Birmingham isn't at that situation at the moment, but we're currently on a watch list. Now, we're way down the list in terms of that watch list, but clearly, we're under some level of scrutiny, so we need to make sure that we're doing the right thing. So the Operation Eagle response, I think that's something that Nick is going to talk to later. So I'm going to move beyond that. So in terms of testing, I'm conscious of time, and I know there, as the leader said, there's a lot of slides here, some of which you've seen before. I think possibly the highlights to say is in terms of the lateral flow test, that our fixed lateral flow testing sites and collection sites have now closed, and that's in line with the national move to home testing. And we ordered the home testing from the government website, but testing is available at our network of 104 community pharmacies. We also have pop-up collection sites, and there's a homeless lateral flow inclusion pilot that we're doing at the moment. So I just kind of move on from there. Stop me if you want to get more details about it. This just reflects the different age groups, and what we're seeing in terms of testing rates. It's probably higher in the kind of school to college age groups, as we might expect. Okay, so going on to case demographics. As you can see here, as we initially seen as case numbers were falling since the start of lockdown. However, if we compare the week ending the 23rd of May to the previous week, there's been a 40% rise in cases for those aged between 20 to 39, and an 85% rise in cases for those aged 0 to 19. So again, it's kind of consistent to what we expect. And again, this is probably just reflecting the same sort of data and case rates by age again. So that trend, these are just different ways of representing what we have really seen anecdotally, with an increase a noticeable increase in the 10 to 19 and 40 to 49 age group, which probably reflects pupils and their parents in the week ending the 23rd of May. And this is, I think, this is again a similar kind of data in terms of the age group, so a bit of replication there. So I'll move on from that. We can see there we were doing really well in terms of the case rate in the population age over 60, with the constant trend downwards, but we are beginning to see a slight rise in that age group also. In terms of ethnicity, currently, for the most recent week, we're seeing that the Asian ethnic group accounts for the highest number of cases, followed by the white ethnic groups. And again, this is kind of currently a reflection of the same sort of data again, with the Asian and mixed ethnic groups rising significantly from the previous weeks. Again, this just reflects the same sort of numbers here in terms of the Bangladeshi population and Pakistani population of Black Afro-Caribbean. Okay, so they're the kind of key groups that we need to really focus and target on. This is just around case rates for the index of multiple deprivation, and there isn't a huge change in terms of the numbers in terms of the different categories, but a later slide will show you that if you actually look at the testing rates, you'll see that there are greater testing rates in those who are in the least deprived areas compared to those, greater testing in those who are in the least deprived compared to those who are in the most deprived areas. And I think that's why we're not seeing much of a differential from one IMD category to another. I think if we did see equivalent testing rates, I think we would see case rates being much higher in the least deprived categories. This is just quickly in terms of NHS situations. I think we're seeing effectively that if you look at hospitalizations, they are reducing across the two STPs, and hopefully that will continue, but we need to monitor that carefully. And in terms of deaths, if you're looking at deaths within 28 days of a positive COVID test, there was no deaths in the week ending the 23rd of May. But if we look at COVID-19 being mentioned on the death certificate, if we look at the week prior to the 7th of May, we saw 3 registered deaths in Birmingham, and all the deaths occurred in hospital. And that's just excess deaths. So in terms of situations, so I think we had 40 situations in the past week or so. Education accounting for 24, workplaces accounting for 11, I think social care 3, and clinical settings 2. Common exposure. So overall, the number of common exposures identified had fallen in the recent weeks, but in the last reported week, the 17th of May, all common exposures occurred in education in the 12 to 17-year-old settings. Okay, so contact tracing, there's a lot there. I think just to say that the total number of positive cases in May was 622 with a completion rate of 87% compared to a local target of 80%. You may be aware of this local zero pilot in which, so prior to this local zero pilot, the national contact tracing team would contact the cases initially for the first 24 hours, initially by text and then follow-up calls. And if they failed to make contact, then they'd pass it on to us locally where we'd have a bit more contact information. This pilot was about bypassing that system, so the data would go straight to our local team, and so that we would do the contact tracing directly. So that pilot is effectively over now and has worked very well, and now it's become part of our mainstream service. Okay, so this is just in terms of the exposure activity setting. So over the past 2 weeks, the household category has been the most common in terms of source of spread, with an increase in the unknown category. Okay, so I think you wanted to get an overview of what we were doing in terms of communications. I think obviously communications at the moment and engagement is crucially important, particularly given that there's I suppose two things. I think obviously the restrictions are being lifted. There's a certain sense of complacency, I think, that is creeping in. I don't think it's unique to Birmingham. I think it's a national and perhaps an international piece where people are feeling somewhat fatigued. There are also a lot of myths going on. A lot of myths at the moment in terms of COVID. For example, people believe if they're vaccinated, they're fully protected and can't get the COVID again, which isn't true. Or they believe that they can't transmit it to someone else, which again isn't true. So there's a lot of work that we're doing at the moment. We continue to focus on our champion program, and we've currently got 820 COVID champions. We've good representation of different religions and LGBTQ community, but more representation is needed for males, Bangladeshi and Caribbean communities, young people aged 18 to 30, and people who consider themselves to have a disability. So in parallel, there's an awful lot of work being done in terms of social or digital engagement, whether it's social media, website, or tweeting. There's a lot of engagement with the faith groups. Certainly happy to go into the detail there, but that's an ongoing iterative process. We've just got providers spotlight. So we have, at the moment, our idea is to working with the BVSC. We want to deliver communication networks and telephone trees in conjunction with another 17 commissioned community providers. And so that would be a good way to get some key messages out from one peer to another, or one member of a community to another. So I think that is a sensible initiative. A lot of ongoing partnership, not only with our community champions, but we have a lot of community partners that we either have direct contractual arrangements with in order to reach out to the hard to reach communities, or informal arrangements where we support them with information and champions and marshals if necessary. So, and particularly we're using them at the moment to communicate in relation to the variants of concern. And then there's further work and development. We have this 440,000 Community Champions Fund from the Ministry of Housing and Local Communities. So, we've established a communications and engagement program to strengthen our relationship with the residents, linking with businesses, with youths, and with vulnerable groups. And again, it's about getting those key messages out there and reinforcing the good practice. Okay, so that's kind of a whistle-stop tour. Hopefully I didn't go too quickly, but happy to take any questions.
Well done, Darry. You did very well to get through all those slides in so short amounts of time. I just wanted to come back to the issue of the Indian variant of concern, because we've seen elsewhere in the country, particularly Bolton and Blackburn and Darwin, that case rates have rocketed up as a result of the Indian variant. And I think it's still too early to tell what impact that variant may have, and whether or not it may affect the roadmap out of lockdown. And sure, everybody's aware, June 21st is the next date on that roadmap, where all restrictions are planned to be lifted. And I do wonder, given that in discussion with the Director of Public Health earlier this week, we were being told that if case rates do start to go up, and your slide indicated there'll be a slight increase, that we might reach a tipping point and then suddenly see an exponential growth in case rates. And we've got to bear in mind there are still large numbers of people who have not been vaccinated. And of course, as you've said, Dara, even when you're vaccinated, you're not 100% protected from this virus. So I do wonder about some of the messaging that the government are putting out here, because you use the word complacency. And I do think that people perhaps need to be reminded that this virus is still very dangerous, and it will seek out people who are vulnerable to it for other health reasons, or indeed those who haven't been vaccinated, which essentially is what we've seen in Bolton and Blackburn and Darwin. I do think we need to be cautious and reminding people that they should stick to the guidelines as they currently exist, the hands, face, space guidelines, and should really take care, particularly when going to indoor venues, because you're much more at risk indoors than you are outdoors. And if you want to comment on any of that, Dara, or indeed any of our NHS colleagues in this meeting, whether they might want to comment.
I mean, the other thing I would say, I absolutely agree with you. I think we need to recognize that viruses have been around long before human beings, and they are built to survive and adapt, and they will continue to try and adapt, to whatever immunity we provide or whatever we throw at them. So we just need to recognize that we may have, won the battle initially, but we haven't won the war, and we have to continually recognize this pandemic is still very much active, particularly outside of the UK at the moment. But we know with alleviations of travel restrictions that there's a risk that more of the impact globally will actually start impacting us locally and regionally.
Thanks, Dara. Steve Graham.
Thank you, Kent. So just the one thing that I wanted to add to what Dara has said there is that whilst we've spoken there about personal responsibility, the one thing to remember is that if people have got COVID, they do have to isolate. And along with Mark's team in environmental health, given I know this is broadcast to people across the city, there is enforcement activity taking place to ensure that people are self-isolating. And if they don't do so, not only are they doing the wrong thing morally, they're doing the wrong thing legally as well. And clearly we'd rather they did the right thing for the right reasons. But I think it's right that people also know that alongside the environmental health, West Midlands Police will play our part in enforcing that law.
Yeah, thanks, Stephen. It is worth repeating that if you do have the symptoms of the virus, and if it is confirmed you've got the virus, you do need to self-isolate for the safety of others and indeed your own family. You need to take precautions because there's still the possibility, even though the vaccines have brought down the level of hospitalisations and deaths significantly, it is still possible to die from this virus. Dr. Munir Aslam.
Yeah, I would echo that, Councillor Ward. I think we need to take a cautious approach here. We have suffered in this region more so than nationally. We had a longer sustained peak on the first occasion. We had a more devastating second peak. We are in danger of having a third peak here. All of the things that Dara's talked about vaccination levels in communities. He's got a couple of slides later on that show 4 areas within West Birmingham where the vaccination rates are not sufficient enough to control a massive spread of this deadly virus. And if it's more contagious, and we need to know that, if it's more contagious, it's going to spread even quicker. And we know the trend. We've seen it now. It's not new to us. We know the trend of younger people being infected, leading on to older people being infected, and the hospitalization that leads to, and the trauma in people's lives. So a cautious approach is what I would suggest. I don't think we are in any way, from what Dara's described, out of the woods here. We've got lots of work to do. We've got lots of people to vaccinate. We have vaccines for those people. We need to get on and do it.
Thank you. And yes, I would encourage everyone, when their turn comes to take the vaccination, do please come forward and have it. The vaccination, I've said this many times in these meetings, vaccination saves lives, and that has been proven with vaccination regimes in the past, and this one is no different. It gives you protection against the virus. It's not 100%, but it does reduce the chances of you being hospitalised, and it does reduce the chances of you dying from this. So please do come forward and get the vaccination. I had my second jab this week, and I'm somewhat relieved to have received that. Okay, if there are no further questions or comments, we will note that update from Dara, and we'll move on to item 7, which is the report back from Operation Eagle, and we have Nick Fell, Programme Manager in Neighbourhoods, to present this. Nick, over to you.
Thank you, Leader. I'll just get the slides up on the screen, and if you let me know when you can see them. Hopefully you've got them there.
Yep.
Fantastic, thank you. So thank you, Leader. Good afternoon, everybody. It's nice to be presented to this group. I've been asked to provide a kind of operational overview and update on what's referred to as Operation Eagle, also referred to as surge testing. So I'll kind of talk you through the approach we've taken. You may be aware that we've just completed 3 parallel surge testing events at back end of April, beginning of May. So as you'll see from the slide deck, there's some detail in some of the experience we've had there as well. So I'll use that as the example. So just to make a start, so I wasn't sure quite what the background was into people on the call. So for people perhaps who are less familiar, just a few statements about what Operation Eagle surge testing is. So Operation Eagle is the project name nationally for surge testing activity in relation to variants of concern. And as kind of Dara alluded to, there are other activities that happen before a surge testing event is sort of initiated. Lots of enhanced contact tracing, trying to work out where cases of variants of concern have come from, and to try and identify whether that's contained. Surge testing generally happens when there's a concern that there may be an issue around containment. So it's a containment strategy to try and make sure we don't let the variants take over in a particular area, usually 2 weeks, and very targeted on postcode to try and encourage everybody, residents and workers in that area, to take a PCR test, whether they've got symptoms or not. And those PCR tests are then sequenced. So we're not only identifying whether are positive cases, but if they're positive, whether they offer a particular variant of the virus. In the case of the 3 operations we've just done, just a little bit of information. So on each one in terms of where the cases were. So Operation Eagle 2, which was 1 case, but someone travelling between Birmingham and Sandwell, and in fact Sandwell had kicked off an Operation Eagle just before we started. The person in question was considered to be a resident of Sandwell, and then identified actually to be living in Birmingham and travelling between the 2 areas. So that was the reason that we were asked to do the surge testing there. Operation Eagle 3, someone with no history of travel or contact with anyone else that we'd identified. So that sort of immediately triggered a concern about where that case had come from. In the case of Eagle 4, 2 cases in a family cluster, and again some information there about no source had been identified and use of public transport without a mask. So again, a concern that there might have been a spread of the variant in that case. All of those 3 operations were related to the B351.1, South African as it's referred to, variant, rather than the April 02 Indian variant as it's now referred. So that was the reason that they were triggered. In each case, we were asked to then sort of initiate surge testing operations as we do. Just really to give you an indication, so 3 different parts of the city, not too far apart in geographical terms, but we define with public health colleagues a target geographical area. So we get a list of postcodes And I just tried to annotate the map here, that the postcode maps aren't as clear as they could be, so hopefully that gives people who are familiar with the city an idea of where they are. As you can see, the first one was around the sort of city hospital area. The second, Operation Eagle 3 in this case, was in Adam Rock, Ward Endon, and the Eagle 4 was Borsley and Highgate. So we identify the postcodes, that's our target area, and what we're really doing is trying to encourage everyone who lives in that area or who has come into that area for work over the previous 4 or 5 weeks to get tested. So it's really about trying to mass test as many people as we can in that targeted area. In terms of the timeline, so I'm just going to put the timeline here for the 3, and as you can see, very much 3 operations running very much in parallel. And what happens prior to us being asked to initiate surge testing is there's a regional meeting which is discussing a particular case, or in this case there were 3 meetings for 3 different cases, where a recommendation is made regionally if they feel that surge testing is required, and then signed off nationally by Public Health England and the Department of Health and Social Care to actually initiate the action. So we're aware of there being a possibility, but actually when we get the agreement, we're really asked to mobilise within 24, 48 hours and really sort of make sure that we're out getting the tests out to as many people as we can. And actually one of the things that slowed us down a little bit, only slightly, in Operation Eagle 2, is actually we needed to get testing kits delivered. So it's not until the operation's been approved that we get the test kits delivered from the Department of Health and Social Care. And you know, no criticism, it's a very quick turnaround, but actually with Operation Eagle 2, we could have actually started on the Saturday had we had test kits available. In the end, we had to delay it by a day to Sunday because the test kits didn't arrive until Saturday. So certainly for public health colleagues and my team, very fast turnaround. The aim really is from getting the green light to get out there as quickly as we can. Just to point a note on this slide that the grey sort of period in the 8th and 9th of May over that weekend, normally we'll do surge testing for 2 weeks in each case, possibly a little bit less if we feel we've really saturated the area as best we can. In the case of Operations Eagle 3 and 4, we still had some businesses where we hadn't collected some kits back in, so we extended that just through to Monday to allow us to collect in as many kits as we could from some of the organisations and businesses that we'd engaged with. So just to talk you through kind of probably key point really in terms of our approach, what we do when it comes to surge testing and how we go about it. Sort of 3 key elements to this. So in terms of engaging with the residents and getting test kits and getting residents tested, the primary strand of activity in that regard is we set up door-to-door delivery and collection. So we have teams out on the streets. They're given target addresses and postcodes each day and asked to go out and knock on doors, engage with residents, engage with the public, explain what we're doing, why it's important, and make sure that we're sort of persuading as many people as we can to take a test kit. The team will then arrange to collect those kits back in either the same day, often the next day, to give people time to do the tests, and then we'll collect them back in again. In each location, we will try and identify a local, what we call a kind of drop-off point. It's a staging point, and my team will staff that point with a couple of people, basically to make sure we've got a point for the door-to-door teams to coordinate from, but also that's where the test kits come back to when they've been collected back in, and then the team will make sure they get sent off to the lab from there. And probably worth just using this forum to thank a couple of local organisations. So in the case of Operation Eagle 2, Birmingham Central Baptist Church kindly gave us access to their building as our staging point. Operation Eagle 3, the Ward End Fire Station was used as the point, and actually for Operation Eagle 4 we used the Hippodrome Theatre where we were already doing some testing anyway. So thank you for all 3 of those organisations, and it's really helpful that organisations like that are able to give us access to their buildings and give us a point to be sort of situated at within the local area. So that's always appreciated. Local testing sites, LTS, so these are the Department of Health and Social Care operated testing sites. They're normally sort of PCR sites currently, PCR testing sites for symptomatic people in the morning, and they're handing out lateral flow test kits in the afternoon. We turn on sequencing at all of those, so anybody who goes to one of those sites in that area who gets the test, whether they're in our target area or not, their results will get sent to the lab for sequencing. So we potentially pick up any additional cases in terms of variants through those LTS sites as well. So that's the residents. For organisations, so this is schools, workplaces. We also engage with faith groups and communities in this way as well. Rather than trying to sort of target everybody individually, what we're trying to do is engage with them and try and get them to help us do the testing. So if you're a business in the target area, you've got people living and working in the area or coming into the area from outside for work and have done in that sort of 4 to 5 week period prior to us starting, what we ask the businesses to do, we'll arrange to deliver a batch of test kits to them. We ask them to organise to get their staff to do the tests, and then we will collect those test kits back in from them, normally the following day, and we will then send them off to be processed. So that's worked very well. So it also worked very well with our education colleagues and with schools, and we had some good engagement with faith groups as well. So again, someone else sort of helping to support the message rather than just the council, I think is really helpful in these situations. As far as the business is concerned, we use our contact centre at the council to try and engage with businesses, make contact with them, either by phone, by email, or if necessary, we do send letters. And that whole side of things is organised by the logistics team that I look after, based at the wholesale market. So they will organise all those deliveries, all the collections, and make sure everything gets sent off to the lab for testing. Final strand, and absolutely all three are important, and this really underpins everything, is the communication side, which is really key. We've got sort of particular pages on the council website that are switched on when we're doing surge testing anywhere, and one of the key elements of that is a postcode checker. So you can put in your postcode, check whether your postcode is one of those ones that's in the target area that we're looking at. And in the case of having 3 in parallel, we just expand that, so any postcode in those 3 areas is picked up. Obviously quite serious sort of focus on social media, trying to get the message out that way. Also engaging with local media, had some good engagement with local radio stations in the community, which is really helpful. Again, sort of the sort of community channels that people may be listening to. Again, it's a different voice to the one that they might normally hear from the council, which I think really works. Recognising that a lot of these communities, English may not be the first language for many people, so using translated materials to make sure we're getting to the right people and trying to make sure the message is coming across to them in the right way. And community engagement. So this is key, ward members, business groups, faith groups, really just trying to get to as many different sort of contacts within a given area that we can. And one of the things we've done here is set the team up. So again, we've expanded my team to be able to support setting up of these kind of community engagement events, which work very similar to a ward forum, but actually that gives us a bit of capacity to be able to do those quickly when we need to. So in terms of sort of how that sort of worked for the operations that we've just completed, the 2, 3 and 4 Operation Eagles, a couple of graphs here. So the graph, which hopefully is on your left, in relation to kit delivery and collection numbers. So it just gives you, on the table at the bottom, the sort of target population. That's the number of residents we'd identified that we believe live in each of those postcode areas that we sort of outlined on those maps I showed at the beginning. So that's who we're kind of target. And then that shows the number of test kits we've delivered, and then in each case the number of test kits we've got back from those households. And as you can see, the numbers there actually quite low, actually, to be honest, in those cases. What we did in these operations is, where we were unable to engage with someone on the door, we were putting test kits through the door and asking people to either do them and we'd collect them the following day, or they had the option to post them, or they could take their test kits to the drop-off point, the Baptist Church, the fire station, the Hippodrome. So it's probably important to note that the numbers there are just those the team door-to-door collected back. What we don't have is the ability to track any that were returned by post. So actually that's probably the minimum number of kits were collected back. We would expect more to have been sent through to the lab through the postal system, and a number of people told us that's what they'd done when we went back to collect a kit. So that's probably a minimum. However, I think probably worth pointing out that for Operation Eagle 1, which was the one we did back in February of this year in the Franklin Great Park area, we did see a much higher percentage of kits collected returned compared to those handed out. It was in the sort of 80s, mid 80s at that point. I think one of the key factors of the view of the team is obviously Operation Eagle 1 in February, we were still in a national lockdown. A lot of children weren't at school at that point, and therefore actually probably there was a lot more opportunity for us to engage people. People were in probably more of the time. I think that's one of the struggles here is in a lot of cases we were trying to get hold of people and they may be at work, out, collecting kids from school, and that created a challenge for us and perhaps reduced the numbers in terms of returns. The graph on the right hand side, engagement for residential addresses, just sort of tries to show the sort of total number of residential addresses the door-to-door team were targeting, and then the number of test kits that were returned. But it also shows the sort of number of addresses where they had an engagement on the door, spoke to somebody, but where someone wasn't prepared to do the test for whatever reason. And the percentage at the bottom really just, we use that as a gauge of whether we've saturated or been able to saturate the area in terms of engaging with people, either to give them a kit and get a kit back, or at least to have a conversation and been told they weren't doing a kit, weren't going to do a test for whatever reason. So just to kind of follow on from that point, really, this is information that sort of came back anecdotally from the team rather than quantitatively, but what we found in terms of reasons for people not wanting to do a test, so where we'd engage with someone on the door, the team obviously will do what they can to try and explain the importance of testing, why we're doing it, all the things that have been mentioned on this call already by others, certainly. But the sort of reasons we're getting back, and the first 2 or 3 are the ones that were most prevalent in terms of the responses compared to the others. But people not really believing in the cause, perhaps were anti-vaccination, therefore anti-testing, concerned about COVID and it being a conspiracy, or just didn't see it was important or necessary, or that they had the time to do it. And that's, I think, really is a concern, and perhaps comes back to some of the points that I made earlier in this conversation about sort of the general sort of state of people's thinking. People saying actually vaccination they'd already had a vaccination, therefore didn't feel the need to test, which isn't the case. And again, the team will try and explain that to them. But obviously we can't force people to take a test, and therefore if people are adamant that they don't need to, then it's difficult for us to do much else. And then the third one, I won't go into all of them, but certainly people sort of concerned about the nature of the test. It is an uncomfortable test. It's not the nicest thing to do. It's obviously something that takes time. We did operations 2, 3 and 4 during Ramadan, and there was a sort of concern from some people on the doorstep around whether or not that doing a test, doing a swab, breaks your fast. We had spoken to a number of the faith groups, a number of the mosques, just to sort of discuss that with them, and the feedback we'd had from them, and we did again try and convey this on the doorstep, was the view was that doing a swab was much like cleaning teeth, and the view was that cleaning teeth is an acceptable thing to do. It doesn't break your fast, but obviously people have their own beliefs, and we can't sort of challenge that on the doorstep. So that obviously is an individual choice at that stage. Only one I was just going to mention was number 6. In terms of occasionally we found people who were kind of elderly or vulnerable, living on their own, and couldn't do the test themselves or found it difficult. The door-to-door teams aren't set up to do the testing for someone. They can't assist someone in doing a test. That's not the remit they're given, and sort of clinically they're not trained to do that. What they will try and do though is work with that individual if possible to see if there's a neighbour or a friend or a family member who will help them do the test. So we do certainly do as much as we can to support that. And just on the final slide, just sort of in terms of lessons learned after each of these operations, we do sort of regroup and sort of take feedback. They generally get started very quickly. It's quite a sort of frenetic 2-week period, and when you're doing 3 at once, it increases that sort of frantic nature. But it's important then to review things. What I just wanted to pick up on was certainly from the team's perspective, Operation Eagle 1 in Frankly Great Park was a learning curve for everybody. It was a very short notice setup, and sort of I have to say, the team did a grand job, but we learned a lot of lessons out of that. And I have to say, operations 2, 3 and 4 were remarkably improved in terms of the speed of response and generally just the operation. That said, there's always things we can improve, and in every case we try to make sure we're doing that. And I think 2 of the key learning points really coming out of the most recent 3, that importance of early community engagement. So I talked about setting the team up to do ward forums, so in operations 3 and 4, the ward forums perhaps happened a bit later in the 2 weeks than we would have liked. So being able to engage with the community, getting everyone together for sort of an event where we can explain what we're doing earlier in the process just gives us more chance of getting to more people, getting more support, and getting the message out sooner, which I think is key. And what we also learned was shifting, given the fact that people are no longer in lockdown in the same way as they were in February, staggering the door-to-door team so they operated later in the day. So perhaps we were getting an afternoon, a tea time after school visit, and then possibly even going back and speaking to people sort of early in the evening. I think is key to just trying to increase our chances of catching more people at home. And that's
Thanks. Yeah, thanks very much for that. Just getting a little bit of an echo there on my speaker. Yeah, a couple of comments from me, Nick, because I think that's a huge logistical task carrying out these Operation Eagles. And just on your last slide there, you had reference to Ward Forum. I think one of the lessons we need to learn may have been in Operation Eagle 3, I think, where the Ward Forum meeting was an optional rather than a required element of the operation. I think if we have to do this again in the future, we do need to make sure that the Ward Forum is mandatory. It has to be held, no matter what the views of the elected members might be. And then my final comment is a little bit tongue-in-cheek, but your very last bullet point, those of us on this call that are in the habit of knocking on doors to pester people for their voting intention would have been able to tell you that later on in the day, you do catch more people in than earlier in the day. Right, anybody, any other comments, observations, questions? No? Okay, thank you. Thanks very much, Nick, for that presentation on Operation Eagle. Very, very informative. Item 8 then is the vaccination rollout and uptake. And as we know, the vaccination rollout has been the real success of the period of the pandemic, which now stretches back over 12 months. We have Dr. Munir Aslam, who is a GP director of Sandwell and West Birmingham CCG, and Paul Sheriff from Birmingham and Solihull CCG are going to update us on the vaccination rollout. I think we'll start this time with Dr. Munir Aslam.
Yeah, thank you, Chair. I won't talk to the slides if that's okay, because I'll let Paul talk to the slides if that's. I think what we described and Dara described earlier on is a sense of urgency now around the vaccination programs. While I accept that we've done well, we haven't done well enough for me to feel comfortable that we are in exactly the right place. And I think that's something that I would like to get across here today. I think it is really important, particularly around the challenges in West Birmingham. And there are some slides in the pack that talk to the level of vaccination uptake in West Birmingham in 4 of the wards there, in Ladywood, in Aston, in the Jewellery Quarter and in Lozells. So where the uptake is significantly lower than we would like, and not just significantly lower than what, but dangerously low in an environment that we are talking about a new variant that is rampaging, has the potential to rampage through communities. So I am genuinely concerned about the state of where we're at the moment. Now, we are talking about, we have gone through a process now where the vaccination program has been ramped up. We've decreased the time between vaccinations to 8 weeks now, which has come with its own logistical challenges. And we still remain in an environment where we've got constrained supply. Now, given what I've just said about West Birmingham in particular and the constrained supply, what we have done is preferentially close down the Aston Villa mass vaccination site, which sits in those communities. As you know from the geography of the city, it sits in those communities. And so we've missed out on a mass vaccination site, although the Millennium Point is close by. It doesn't predominantly seem to cater for the West Birmingham population. So it is something that we are concerned about and we need to do something about. And I'll go through the kind of 3 tiers of the plan that we are developing. We have talked about pharmacy vaccinations. I mentioned it last time. We've had 27 pharmacies come through for approval to provide vaccination access. And unfortunately, NHS England has only approved 2 of them. So the process for approving pharmacies or increasing the opportunity for people to have vaccinations is not quite as good as we would like. And so we're working with NHS England to improve that. I suppose if we start with the data, I think there's work for us to do with Dara and Justin's team to make sure that we have all of the data that we need to understand street by street who's been vaccinated, who's not been vaccinated, where can we park vehicles that might be able to offer vaccination, how can we improve the access into vaccination for those people in low vaccinated areas. And I'm talking about all of the areas in West Birmingham in particular, and Paul will talk about the others. We have particularly low uptakes in the African and the Bangladeshi communities, and that is a concern to us because they make up a large portion of that population of people. So I think there's something about we've got enough AZ in the system, so the AstraZeneca vaccine. We're going through a process now where we're increasing the number of general practice sites that will have access to Pfizer and AstraZeneca, and we're going through an approval process for that at the moment, which we aim to get done very quickly. So by the end of next week, we'll have 8 new GP practices that are on site to deliver this vaccination program. We'll hopefully have got them through an approval process to help cater for second doses, and all those people in the cohorts 1 to 9 that have missed their vaccination opportunity but can get vaccinated. They've changed their minds. We want to make access easy for them, and then to move on to the other cohorts as well. We are gearing up for the challenges around this, and I spoke about the urgency to start with. I think we are gearing up to vaccinate on a even more enhanced basis, so quicker vaccinating people, quicker to get them onto their second vaccinations as well. And so I think we need to gear ourselves up for that. So I think there are, although we've done well, I think there remain some challenges, particularly in West Birmingham and other areas within Birmingham, and they are matched to the areas of deprivation. So where the deprivation is high, the vaccination levels are low, and that's talked to in Dara's slides as well. So while I think we are in a good place, I think we could be in a much better place, and I think we do need to keep that sense of urgency. COVID is here. There is a variant. We've seen all of the challenges that India have had dealing with this particular variant, and you know, it reminded me of looking at what China were going through a year and a half ago and thinking that would never happen here. And it happened here, and this has the potential to make it happen again. So I am really concerned. So I would encourage, you know, the bits that are missing in the jigsaw about making the data add up, about making sure that supply is available and access is available in those areas where uptake is particularly low, and making sure people are encouraged and able to get the vaccine at an appropriate time. They're all key messages. They're messages we've said time and time again, and I'm really keen to reiterate those. The messages and messaging has not changed. Get a vaccine, get it quickly. We're going to make access easy for you, and we'll work with communities particularly, and we'll support financially communities to work together so that they can encourage members of their communities to get vaccinated, and that's part of our agenda as well. So while I'm happy that we are where we are, we've delivered almost 1 million doses of vaccination into the Black Country in West Birmingham. We are nowhere near where we need to be, and I'd just like to reiterate that sense of urgency.
Thank you, Munir. What's happening and has happened in India is truly, truly awful. We wouldn't want to see anything like that start to happen here. So I can only reiterate what you've said, really. Do come forward and get the vaccination. If you have any reservations or doubts, then do speak to a health expert who can talk you through the exact reasons why it is far better, far safer, and far better in terms of protecting yourself and your loved ones that you come forward and have that vaccination. Paul, do you want to talk us through the slides that are in the agenda papers?
Yeah, thank you, Chair. I won't take us through all of the slides because I think there's some further information that's been included in the additional pack from Dr. Varney a bit later on. I also won't go over any of the ground that both yourself and Dr. Aslam have just covered around the key important public messages. But I do have a view that I think the programme is going well. I do support the view that there is more to do. The numbers are very significant now, but they do highlight areas of inequality, and I'm sure members and the public will be well aware of those observations from the information, and that's the target really of a lot of our work at this current time. So we are focusing on increasing uptake in cohorts 1 to 9, in particular the areas of low uptake, as Munir said, in West Birmingham and also in areas like East Birmingham and central parts of the city. There is a real push on second doses, and I would want to get a really strong message across to members and to the public how important it is to make sure that you attend for your second appointment. We are seeing numbers of people actually not responding to their follow-up appointment, so we are having to focus on recalling people for that second dose, and that takes an awful lot of time and energy to chase people that have missed their second appointment. So we would really encourage diligence from members of the public to make sure that they keep their second appointment the increased protection that you get from 2 doses is significant. So that is a very clear message we would like to get across to the public. As Munir said, there's also a significant challenge, and it's mentioned in the slides. We have brought forward the second dosing regime from 12 weeks to 8 weeks. And I think for this system, it's probably somewhere the data is always very difficult to pin down, but it's certainly over 150,000 appointments that we would have had to have brought forward from 12 weeks to 8 weeks. And that presents a huge logistical challenge. So that's also been a significant component of our focus over these last few weeks. More recently, in relation to some of the items that have been discussed earlier on the agenda around new variants and concerns from a public health perspective, the surge response is now being developed. And this has been touched on, I think, in part earlier on, but we will have a mobile pop-up service where we will be going into communities where we're thinking we're having increased prevalence of any new variant and being able to provide local accessible vaccination. So again, a very clear message, and we will work with communications colleagues, is to make sure that's publicised so communities can take up that opportunity. I suppose the final thing that I would want to kind of touch on is how we plan for the next phase. It's always very challenging not to, it's to concentrate on the here and now, the position this week or today, and not look further ahead. And I know it seems probably bizarre to consider what might happen in the autumn and winter, but as Munir will be aware, we're now having to planning for what we call phase 3. So these are potential COVID booster vaccinations, as well as the seasonal flu campaign. And there are a number of scenarios which I won't go into this afternoon, not least because I still need to fully understand them, but we're working with our colleagues in NHS England and Improvement to model through a number of different scenarios, which may include younger children to being vaccinated and certain age ranges of the population around their second or their third booster vaccination. So I'll probably leave that there in terms of an overview, if that's okay, Chair, and happy to take any questions.
Thanks very much, both. And we've got a question or a comment from Dara. Dara.
Right, thank you, Leader. It was just really on the back of what Paul had said there, something I had meant to say during my own presentation in terms of the second dose. I think what they're finding in terms of the Indian variant and vaccine susceptibility, that if you get one dose, the level of immunity provided is not as good as you would get against the Kent variant if you were to get one dose of the vaccine. But if you were to get 2 doses, then you get equivalent level of protection as you would against the Kent variant. So it's even more important to get the second dose with the Indian variant circulating than it is with the UK variant circulating. So that's why I think there's a particular focus on getting that second dose to get that level of immunity.
Thanks, Dara. Yeah, and I think we can't emphasise enough that people need to come forward and be vaccinated. But yes, you need to get that second one, second jab as well, because it does give you more protection than if you just have the one. And that's a point well worth making. Anybody else? Any comments on this, Munir?
Yeah, I just wanted to recognise what Paul has said about the vaccination programme now, and then what we will be expected to do in September with a limited capacity. So there are trade-offs here, as there always are, and I think we need to buy into them together, because actually to run a vaccination programme at this scale on a once basis, on a second basis, and then in the autumn again on a third level is a massive endeavour, and we haven't gone through it unscathed this time. We're still picking up the pieces of high deprivation areas where the vaccination rates are low, so the challenge again will come to us in autumn. So it does involve a significant logistical effort to do this, and primary care are delivering the vast majority of the vaccinations, but there is a primary care problem as well in terms of demand that has been suppressed by going through a lockdown and now resurfacing. So the demand on general practice is now probably 150% of where we were a couple of years ago. So we're dealing with that demand, trying to recover as well from our chronic disease reviews and all of the support that we give to people with chronic diseases. And then on top of that, to run a vaccination program that is much more significant. We are vaccinating half the population. So it's just, and in the winter, we will try to vaccinate almost the entire population because we'll try to do flu and COVID at the same time. So it is the logistical challenge. I just don't want people to underestimate what we're having to go through here. So there are trade-offs, and the trade-offs are we have to stop doing something to enable this to happen. And so we'll need to talk together with the public about what exactly that means.
Yes, thank you, Munir. That's absolutely right. I'm sure we've all been reading in newspapers about lengthening queuing lists for other forms of medical operation because of the focus on vaccination. And as wonderful as the NHS is, there are limits to what can be achieved. And as you point out, there's a trade-off here with effort going into vaccination. Okay, if there's no further comments or questions, can I thank you? Paul?
Sorry, Chair. I just wanted to just come back in, if I may. And it was something I intended to say at the beginning. I just wanted to place on record, if I may, to my colleagues that work on the front line and to all partners across the system. We've delivered, I would say, nearly 2 million, if not over 2 million vaccines across the Black Country and West Birmingham and Birmingham and Solihull. So well over 1 million vaccines have been delivered in Birmingham, and that is a huge effort. And that's taken all parts of our system. It's GPs, it's hospitals, it's the community trust, it's the local authority, it's colleagues right across the board. And I just want to take the opportunity to say I think we should acknowledge that, and I welcome continued support from all partners.
Thanks very much for that, Paul. I think you are absolutely correct that what we've seen throughout this pandemic is an extraordinary effort from all parts of the public sector in helping to get people through what has been an unprecedented period of time, something none of us would have predicted as recently as a couple of years ago. So thank you. And thank you both, and thanks to everybody in the NHS for what you continue to do. Moving on then to the enforcement update, we've got, as ever, Mark Croxford and Chief Superintendent Steve Graham. Mark, are you going to kick off this presentation?
I can try, Leader. I'm not very good at doing two things at once. I also apologise. I'm on a 4G card, so hopefully you'll get the presentation. Can you see that?
Yep.
Real. I must get better at doing two things at once. I get told.
We'll turn it into the slideshow, Mark. So
yeah, I'm just trying to find it. That hopefully
there we go. Perfect.
Okay, so there has been quite a significant change in focus, and Steve will talk about that. We had a conversation, I think, at the last board. I've also had a conversation with Steve and his colleagues, and we are looking very much more at as much education as we possibly can, but I will return to that as I go through the presentation. So we've been doing a lot of noting of any problems that we've found and advising people that if it isn't compliant, if it's relatively cheap to make a change, then please could they change it, rearrange a table, put it in a slightly different place. But if there's a cost implication, we haven't been asking people to incur greater costs, we've just been trying to support them. So that's been going on as we're going through stage into step 3 of the roadmap. So we've continued to give out the face covering. Further 7,000 have been given out, which is great in the sense of people are taking them and people are using them. And the more that can continue, the better, because as you've heard, COVID isn't going to go away overnight, even if the dates go past, and it is still about fundamentally personal choice, looking after yourself and looking after your colleagues and your friends and your family. We continue to patrol the high footfall areas. They're much less enforcement orientated, as I've said, giving advice, trying to help with queuing, talking to people outside schools, trying to increase the numbers of people that can use the religious establishments and food banks at any given time. Anywhere where there's a bit of pressure, we're trying to help out as much as we can and give support. We were also working around with the police and trading standards around the recent Chandrat, and also trying to support people with prayer outside at the mosques as well in the last month. The park COVID marshals still patrolling the parks. They have seen quite a reduction in compliance with the legislation, in that only about 70% were compliant. That means there's been gatherings which have been greater than the numbers that were permitted. But as we move forward and people are now permitted to meet indoors, that's becoming less of a problem. hopefully we'll see better improvement on that, or on the compliance rate. And those are the parks where we've been patrolling and giving out advice. We are getting ready for or have been speaking to businesses. Really pleased that there's been a great reduction in the number of complaints that we've received as we've moved from stage 2 to stage 3. So that's been a really positive step, and really pleased with the effort that everybody's making to do it as in as good common sense way as possible. And there's some numbers there as the businesses that we've been talking to. With regard to test and tracing and dealing with contacts, the officers are still doing that. There's been a significant improvement with Local Zero, which is the, if I can be crude about it, and the local authority doing some of the telephone calls and the test and tracing. That's reduced the number of visits that we're having to make, and we've really improved on getting information in. At this point, I just want to make the point, and I'm really sorry to those that I've talked to earlier in the week because I'm on my high horse again. I do apologise to them, but we keep talking about test and trace, but it is test, trace and isolate, and it's really important that we start using this term test and trace and isolate. So if we have positive cases, we need the isolation to break the chain. If we just test and trace, we're going to end up with a lovely picture like we've got on the slide, so we're going to know where all the problems are, but it's then going to be populated with even more dots as we identify where the problems is. So I've been asking people to use the three terms: test and trace and isolate, and it's really important that that message is coming out. We have had a few difficulties around the businesses, the individuals that we've gone out to check to see whether people are isolating. Steve's team have been absolutely fantastic in offering support to come out with this if we've needed it. We were at one point running at a 40% rate of non-compliance, so people who would come home from work or come home from the schools, not everybody in the family was isolating, but I'm really pleased to say that the work that we've been doing, the education and the requesting people to comply has been everything that's necessary so far, but we will continue to do everything we can to break the spread of any of the outbreaks that we come across. We continue to support the faith groups, and it was a very important time just gone by. We've had really good feedback on that and really good cooperation, and that's been absolutely fantastic. I'm just really sorry that you know it again occurred in the period of a lockdown. Hopefully, fingers crossed, things will be better as we go further into the year and next year, and that'll be the last time we need any lockdowns around that. With regard to the statistics, they're all there, Leader. I don't propose to go through them unless anybody's got a specific point, but the numbers are all there, but they are numbers, and I've given you the background to it in verbally.
Thanks very much, Mark. Steve Graham, anything from the police side of this?
Thank you, Ken. So sadly, I haven't got as many fancy graphs as or charts as Mark, but if anyone does have access to the document, my reporting starts on page 117, but I'll just give a little bit of the background narrative as to what the police have been doing roughly over the last 6 weeks, which is the time frame of this report. One of the things that's important to bear in mind when we do come to the data later on is to reflect that that's quite a lengthy time frame, and it also covers a couple of phases, whereas Mark has said we've been going through the various steps there and the various phases within some of those steps. One of the things that we've started to see, which is making enforcement fairly challenging, has been a rise in the number of protests in Birmingham city centre in particular, but across the city as a whole. And clearly, you know, we the police and working with the teams in the council, we recognise the lawful right of people to protest. But one of the phenomena that we're experiencing recently is protests that don't have a formal organiser, and that's made negotiations for us and colleagues within the city council difficult in this, or not only impossible, because people are supposed to provide us with a risk assessment to show us how they're going to manage the risk of COVID-19 as well as other risks too. And so what we're seeing now is, it's great to see public movement, and it's great to see people coming out to protest about things that they feel passionately about. But at the moment, it's not being done in a particularly safe way. And what we're now finding, it's really difficult for us to walk the balance between policing legitimacy and being seen as clamping down on people protesting, particularly if it's something that people think the police might not agree with one way or the other. And then try to actually enforce the COVID regulations and, you know, give guidance around the governmental guidance without being seen as being overly oppressive and being disproportionate. What we saw over the weekend just gone was 4 protests in Birmingham City Centre, 3 of which were all in Victoria Square at the same time, and that made the policing of that really quite challenging. The Free Gaza protests that we're seeing at the moment pop up all over the city, and we know we've got more scheduled for this weekend. They have no event organiser, and I would contrast that with what we've seen outside the Indian consulate and the animal rights protests we had in town over the weekend. When we have event organisers, we can find out what they're going to do. They turn up with marshals and stewards, and advice is given around masks and social distancing. Whereas what we saw with the couple of the large pro-Palestinian demonstrations that started in Victoria Square and then went on spontaneous processions around the city centre, there was no masks, no social distancing, no stewards. It wasn't done in a safe way generally. And we have got some concern as to whether or not that's going to lead to some transmission in the short or medium term across the city. So I just wanted to share that, number one, for your information, but also in case there are any people who are watching this live stream live or will watch it back, because it is something that if we do step in as a police service, we're enforcing for the public good, not for any sort of political protest or political statements on the subject matter of that process. When it comes to enforcement, and this is all now covered in paragraph 310 of the report onwards, people will see that the number of directions to leave that we've issued have dropped off significantly. On face value, going down from 1,002 to 669 might not seem like a big drop, but that's the group in March to April was roughly over a 25-day period, whereas the 12th of April to the 23rd of May is a 42-day period. So it's a much longer time frame, a significantly reduced the number of directions to leave. People still see there that we are issuing multiple directions to leave to people, and the proportion of fixed penalty notices have gone up. Everyone will have heard me talk beforehand about the 4 E's approach, where we do try to go to enforcement as a last resort. But we continue to issue fixed penalty notices for people who simply, it sounds really patronising now, that they won't do what they're told. And we are still seeing some unlawful mass gatherings, as Mark described with the change in the legislation. Some of the rules around that are changing, but we are still seeing some city centre pubs, and we went out with Mark's team over the weekend, who are encouraging vertical drinking, who've got DJs who are encouraging dancing, and who are putting on DJs and really loud amplified music. And so just over the weekend, we issued a couple of £1,000 tickets to people in the Arcadian Centre. So it's people who should know better, quite frankly. And working with Mark's team, we were able to take some really prompt and I consider to be proportionate enforcement action. The last thing that I'll mention later is covered in paragraph 3.12, for anyone who's got the report in them. And it talks about the disproportionality based on ethnic groupings. I don't know if this was covered in some detail earlier on, both in terms of vaccination, but also in terms of infection rates. But I did just want to share some data around the enforcement. You'll see that, and it sounds almost stating the obvious, but if we take the likelihood of being given a fixed penalty notice as 1 for a white person in Birmingham when they're dealt with, you'll see that if you're an Asian person, you're likely to be 0.6 times likely to get a fixed penalty notice. But if you're black, that ratio is now up to 6.8, and that's gone up quite a bit even since the last report. We've done a little bit of digging into this as to where we're issuing fixed penalty notices, and a lot of it is at some of the large and lawful gatherings which are being disproportionately attended by members of our black community, and in particular by our young black community. And again, it was spoken about earlier on how young people can carry the virus and then take it home with them. So when we do get those large gatherings, if we are able to catch people, we will give them fixed penalty notices right from the word go. And we are still seeing that the people who are at those sort of events do on the whole, or are disproportionately from our black communities. And so that's where we are, Leader. In terms of going forward, we will continue to enforce the same way as Mark will do until the June or whenever these restrictions are lifted. But that's my report, and I recommend it for your approval.
Thanks very much, Steve, and thank you for that explanation at the end there about fixed penalty notices, because it's really easy for people to get the wrong impression from just the statistic. And just on the demonstrations this year, I think it is worth repeating what Dr. Munir Aslam said a little earlier. We are not out of this pandemic by any stretch of the imagination at the moment. People do need to continue to follow all of the guidance, and that includes anybody who wishes to organise a demonstration. And I know that it's a difficult line for the police to walk this, because in many ways, you're damned if you do and you're damned if you don't. But I do think myself that some of these demonstrations where they won't name an organiser is an attempt to really get around the rules. And we do need to take a bit of a tough line on this, but emphasise again, the rules are in place for everyone's protection. That's what they're there for. They're not about trying to restrict people's right to freedom of speech or demonstration. Anybody, any questions? Paul?
Thank you. On that specific issue, Leader, I wonder whether Steve and the police are following the social media, because to call a demonstration, there has got to be a catalyst on social media. Things don't organically happen. And I mean, we've all seen the demonstrations taking place. There's been no social distancing, no masks by and large. So it is a threat to the greater public health. And I don't expect Steve to say everything that the police is doing, but I make a presumption that they are watching very closely where the social media starts.
Thanks, Paul. Steve? Thank you, Leader. Yes, Councillor Tilsley, you are right. We do keep an eye on social media. Probably for about 18 months, 2 years, we did see a lot of protests that were organised on platforms such as Facebook. But people have realised that if Stephen Graham promotes an account on his personal Facebook account, then he can be perceived to be the event organiser in law. So what's happening now is that people are circulating it all around WhatsApp on various flyers. And so we're not able to, or they're even using secure and free platforms such as Telegraph, which are harder for us to penetrate. So we can't work out who the source was. And so a lot of people suddenly turn up at either Victoria Square at 2 o'clock on a Saturday, or the Belgrave Road McDonald's at 3 o'clock on a Friday. No one claims to be an organiser. Someone will then assume the right of what they call a spokesperson, which to me sounds like an organiser, but doesn't have the same standing in law. And then they go off and do their business. So we do try. We do scour all the social media platforms. We do have other tools at our disposal, which, as you quite rightly said, I shan't go into here. So we are doing our best, because we want to work with these event organisers to make their protests as safe as possible, not to ban them. We will do what we can to work with people to make sure they can be carried out safely. This isn't about stopping them. We don't ban protests, not as a city, not as a police service. And so people are doing it. We'll work with them. But yes, you are right. We are doing our best to find out how and where they're being organised.
Yes, some of these demonstrations do not make it any easier, and they do put people at risk when they won't name an organiser. And I know, Steve, that there are a number of demonstrations planned for this weekend, one in particular where they've refused to name an organiser. And I know that the City Council has been in discussions with the police about that particular demonstration. Okay, if there are no further comments, thanks very much, Steve. Thanks, Mark. Item 10 is public questions submitted in advance, and we do have a question that's been submitted this month. If you've looked at the agenda paper under item 10, rather strangely, the paper doesn't set out the question itself, but indicates what the question was about and gives an answer. I wonder if I could ask Paul Sheriff. I don't know if you have the question to hand, Paul, but and could read it out. But if not, could you just talk us through the answer?
I can, thank you, Leader. I will do my best to try and find the question, but I have read it in full. But primarily, as the summary indicates, it was a specific question around an initiative within the city to vaccinate in multi-generational households, and whether this had an adverse impact on people that were due their vaccine earlier than that initiative would have enabled other people to have a vaccine. And it specifically references cohort 4, which is people, I think, above 70 years of age and classified as clinically extremely vulnerable. The response to that question is that it would be very unfortunate if that individual did suffer a delay, and I would imagine it would be due to other circumstances rather than this particular pilot initiative. But just to give you some context, the government, through the Joint Committee for Vaccinations and Immunisations, the arm's length advisory body, set the schedule for which vaccines would be administered to the general public, and that was based on clinical evidence and opinion. And the release of vaccine into the communities within England and Wales was set out by them, and that was linked to time schedules. So the cohort 4 that this individual refers to, the clinically extremely vulnerable, opened up on the 8th of March, and the initiative that we developed locally wasn't approved until the end of March. And just to give you a little bit of context, if that's helpful in terms of reassurance, we do not deviate, we're not allowed to deviate from the JCVI guidance, and that has been from the very outset of this programme. Where we do deviate, it has to have local approval, and it went in this case to one of the senior policy advisors for JCVI. The only time that we would ever vaccinate outside of cohort or JCVI guidance is to avoid waste, because we would choose never to waste a vaccine. So in this instance, my response to the question is that actually this particular initiative, which was aiming to promote uptake in those cohorts where we felt that there might be hesitancy linked to the rest of the household not having the vaccine, that pilot programme did not start until after cohort 4 opened up, so it should not and have had any detrimental impact on this particular individual who's raised the complaint or anybody that would be in cohort 4. I don't know if that's a helpful explanation. It's not necessarily a straightforward thing to describe, but I'm happy to kind of set out a more detailed written response, which we've given a summary to within the pack under item 3.2.
Thanks very much, Paul. And as you point out there, the multi-generational vaccinations in multi-generational homes, was about trying to reach those who might be more reluctant to come forward for the vaccination. So I think you've explained how it hasn't impacted on the person concerned who's asking this question, but I do think it's worth reiterating this initiative was about reaching those who might have been reluctant coming forward. Mania.
I was just going to reiterate that point. Don't forget, this is a small population of people that were in multi-generational households. We have always had vaccination capacity in all of our vaccination places. So there's been capacity there. We have been constrained by, as Paul said, about the JCVI guidance, but we've always had capacity. So the real constraint has always been vaccine supply. But given the number of people that have been involved in this household project, it hasn't been a massive number. But they have been significantly vulnerable people, and it has been exactly the right approach. So I can't believe that there was a delay to any other vaccinations because of the fact that there is capacity in the system. But this was the right approach as far as I'm concerned.
Thank you. Thank you both very much. We will note both the question and the answer that has been supplied. Test and trace budget overview, then Dara, back to you. You're muted at the moment, Dara.
Sorry, excuse me, can you see that?
Yes, we can.
Okay, great. Okay, well, look, I won't take up too much time. Obviously, so if we kind of look at the overarching budget for the test and trace unit, if we look at the middle column there, which is really the forecast spend from 1st of April 21 to 31st of March 22, you can see that we have allocated 19 million, or just over 19 million in the budget. However, I think it's important to note that within that, there's a kind of a generous overall contingency of 2.6 million, as well as a wave 3 response contingency of 3.5 million. So if you take that out, then you can see that actually the core spend or projected spend is 13 million. So hopefully we won't need to go beyond that. But at the same time, I think it's important, given the uncertainty around COVID, that we have this a significant contingency pot in place in case we need to increase staffing or various initiatives to try and get on top of any potential threat. So the budget itself, probably quite understandably, is predominantly around staffing. So it's just not only the core staff within the test and trace team, we potentially staff to support community swabbing and support, staff to support enforcement, and that includes the COVID marshals, who are very helpful in supporting the cause. And I think then there's some additional lines there in terms of translation services, equipment, comms, software, health and wellbeing support, whistleblowing, local contact tracing. That's also a staffing cost because it includes those within. They're not actually within the test and trace unit, but they're within their call handlers within the council who reach out to people to support contact tracing. There's isolation support, testing facilities, asymptomatic testing, and supporting compliance. So you can see that we've also gone as far as September 22, which effectively is really 50% of what we've forecast for 21-22. And then if you see the very first column, you see actual spend to date from the 1st of April, which, as you can see, is quite small. It's only 178,000. A lot of that reflects the fact that we haven't either received or paid the invoices yet for spend within that period. So I don't think it gives a very accurate reflection of whether we're on plan, but certainly at the moment we've no reason to believe that we're over plan in terms of our spend. So I think I'll stop there. I'm not sure there's much more to say, but I'm happy to take questions.
Thanks very much, Dara. I think quite rightly we've taken a very prudent approach to this and have kept money aside so that we can deal with any implications that might arise from the current variants that have arisen from different places around the world. Okay, if there are any questions, no, we can note the budgetary position then. Item 12 is other urgent business. Does anybody have any other urgent business they wish to raise? No, okay. Date and time of the next meeting then, if we could note that the next meeting of this board will be held at 2 p.m. on Wednesday the 30th of June, and again it will be an online meeting. Could I thank everyone for your attendance and for your contributions this afternoon. Please do all keep safe. Thank you very much.